All right, we'll go ahead and get started. I'm Allison Kendall. I'm at North Carolina State University. I am chose this article, minimal renal pelvis dilation in cats diagnosed with benign ureteral obstruction by antegrade pyelography, mostly because it comes up pretty frequently for us for having cats and the challenge of sometimes diagnosing ureteral obstruction. And then also, I just spoke at VMX last week on ureteral obstruction, and this actually article came up a lot there too, with questions from referring veterinarians and trying to diagnose ureteral obstruction there. So it's been talking about this article for quite a lot in the last week or two. So I thought it would be a good one to do for this journal club. Mostly also I want to get everyone else's thoughts and opinions as well about the challenges of diagnosing cats with ureteral obstruction with minimal pelvis dilation and kind of some of the challenges we face sometimes in hospitals of getting them to surgery and getting a sub placed. So this article was from the University of Montreal. It was published accepted in 2020, published in 2021 through the Journal of Feline Medicine and Surgery. So just an introduction from the paper, an introduction into ureteral lithiasis. So ureteral lifts and ureteral obstruction are becoming more and more common. And endourology, minimally invasive surgery has almost completely replaced traditional surgery in human medicine. But the difficulty still in veterinary medicine is certainly diagnosing the obstruction, which is where this paper comes into play, and then deciding on treatment options. And then most of our treatment options in veterinary medicine can be limited by finances. So I always loved this paper as well from DACVIM in 2013, looking at a retrospective looking at azotemic cats. And certainly you can see that other than those ones that had no known obvious cause for their AKI, ureteral obstruction was by far the most common cause of azotemia in cats. And then the nice thing about these ones too is they actually, when you look at survivors versus non-survivors, ureteral obstruction has a pretty good survival rate compared to other causes of azotemia. So I like this one a lot for students and referring vets. Just as another reminder not to miss ureteral obstruction in azotemic cats. So why are cats so predisposed to ureteral obstructions? So there's a couple reasons why. I mean, one is probably that their ureteral anatomy, their intraluminal diameter is quite small. It's anywhere between 0.2 and 0.4 millimeters. And then looking at this pyelography image on the left is that a lot of the cats have this kind of J-hook shape as the distal ureter enters into the bladder. So that's another common site of obstruction. And then certainly the other most common site of obstruction is at the proximal ureter, where it tapers quite dramatically. And then still wondering how much gravity plays a role, because certainly in humans, we have gravity on our side versus veterinary patients don't have that. And then other things that play a role is hypercalcemia. We know that for anywhere between 14 to 70% of cats with ureteral obstruction, pending the paper, are hypercalcemic. Cats are also very predisposed to chronic kidney disease. And we know there's an association between CKD and urolithiasis, and then dehydration as well too. There was one paper that looked at cats with ureteral obstruction, cats that were almost 16 times more likely to have a ureteral obstruction if they were fed a dry diet. Etiologies of ureteral obstruction, so still most commonly is ureteral lifts with calcium oxalate making up the bulk of those. Dried solidified blood clots or blood stones, 8 to 10%. Ureteral strictures, circumcaval ureters, inflammatory ureteritis, infection, iatrogenic ureteral ligation, retroperitoneal fibrosis, and trigonal neoplasia. And then up to about a third or so of feline ureteral obstructions do have an associated stricture, which has always made treatment somewhat challenging as well too. So diagnosing ureteral obstruction, so certainly you can start with plain radiographs. If you're lucky, you can see radiopaque calculi, but certainly the challenges are many of these stones, especially in the ureter, are very small. You have superimposition of the colon there, and their membered strictures and dried solidified bloodstones are often not visible. You may also get lucky and see a big kidney, little kidney, which might also be an indicator for ureteral obstruction, but not ruling out obstruction if radiographs appear normal. And then certainly ultrasound is typically what most of us go for initially, can evaluate if it's maybe partial versus complete, which is the location of the obstruction, if you're lucky to see the stone, but the classic sign of hydronephrosis and or hydroureter. And we know that size doesn't really matter for diagnosis, but may make a decision for a management plan. Although that now, especially with this current paper we're discussing, seeming like we're going forward with subs earlier on with smaller and smaller renal pelvises. And then the JVIM consensus statement on urolithiasis in 2016 states that hydronephrosis greater than 7 millimeters with a concurrent hydroureter is highly suggestive of a ureteral obstruction, and that they do state that both radiographs and ultrasound should be done for a more accurate diagnosis. So I like this image because this is also another one that I often will show our house officers and referring vets as well too. But this actually comes from this paper we're talking about now. And so you can see in figure A, the top image, there's pretty minimal pelvic dilation or almost no pelvic dilation at all. But then B shows a pretty severely distended ureter. And then when you look at the radiographs, you can obviously see pretty prominent ureteral lifts with a really large distal ureteral stone. So a couple of things from this that I take away is, one, maybe radiographs do still have a role. We have talked about that too, is that, oftentimes when there's a distal ureteral obstruction, if there's not pelvic or proximal ureteral dilation, it's really difficult sometimes for our radiologists to completely trace the ureter. And so I wonder how many distal stones are sitting there that we just don't see. And so that's where radiographs can play a role. And then also that you can have ureteral dilation in the absence of renal pelvic dilation. And so making sure to look at both of those things, not just looking at the renal pelvis. And then oftentimes with ultrasound too, sometimes you need serial images to diagnose the obstruction. And so this was a case example actually we had at NC State where a young cat had presented with an AKI in March. And I was convinced at that time that the cat had a ureteral obstruction just based on its ultrasound images and the way that the cat was behaving. But could not convince our radiologists or our surgeons, unfortunately. And so we treated that cat, sent it home, came back in April, had a persistent or progressive AKI, re-ultrasounded again, I could not convince anyone to take this cat to surgery. And then 10 days later, now you see nice big pelvis. And so I think I won that bet, and finally that cat got its subs and it's doing great. But sometimes you need those serial ultrasounds as well too to get an accurate diagnosis. And then when we look at diagnostic utility of ultrasound for detection of the cause and location of ureteral obstruction in cats, this retrospective had about a 98% sensitivity, 96% sensitivity for ureteral lifts. And then sensitivity was much lower at 44% for ureteral stricture. And then looking this paper in Journal of Feline Medicine Surgery also looked at ultrasound in the diagnosis and management of ureteral obstruction and found that there was no significant differences in ultrasonographic changes between cats with obstructed and non-obstructed ureters. So Ultrasound is still kind of up in the air and can still be a challenge in getting an accurate diagnosis. So this paper out of University of Montreal wanted to describe the renal, pelvis, and ureteral ultrasonographic measurements in a population of cats with a confirmed benign ureteral obstruction by antegrade pyelography, and then further describe clinical findings associated with minimally dilated obstructed kidneys. So they retrospectively looked at all cats that had had a sub placed from 2012 to 2018. So they were definitely diagnosed, confirmed, had a ureteral obstruction, had a sub placed. So their inclusion criteria was that they had had the initial diagnosis based on ultrasound. So they had ultrasound images of all these cats. And then they had intra-op pyelography performed and a subsequent sub placed. They split them then into two groups. So group 1 is the small renal pelvis, so less than or equal to 4 millimeters. And then group 2 were your classic big renal pelvises greater than 4 millimeters. They then, from the medical records, pulled quite a few, sorry, my Zoom, of course, is like right over the part of the slide that I'm wanting to read. So for medical records, they looked at signalment, body weight, the side of the obstruction, the ultrasound findings, the suspected cause, the presence of dilated pelvic diverticula, which is something we also talk about a lot with diagnosing ureteral obstructions, their serum creatinine, their urine culture results, method of urine collection, and any antibiotic usage. So for statistics, they looked at kidneys and ureters were evaluated separately. And then only the unilateral ureteral diameters were only the unilateral, sorry, that's supposed to say UO, ureteral obstructions had a relationship between the renal pelvis size or ureteral diameter and serum creatinine. They used Anderson-Darling normality for renal pelvis size, ureteral diameter, and serum creatinine. Then they used a linear mix model to evaluate the relationship between the renal pelvic size and the ureteral diameter. They used Pearson's correlation to evaluate the relationship between renal pelvic size or ureteral diameter and creatinine. And then they looked for the difference of distribution of causes between groups 1 and 2. So when you look at the overall total cats, whoops, sorry. Let me go back. So 82 cats total. Most of those, 61% or 50 of those cats were unilateral, 39% or 32 of them were bilateral. And then it was about half and half, with 58% left-sided, 42% right-sided. They had about half and half spayed female and castrated males in the group. Median age was about 9 years. And then when they broke it down into group 1 or group 2, so certainly 3/4 of them were in group 2 or having the large renal pelvic size, but 1/4 of them were in group 1 or having a less than 4 millimeter renal pelvic size, with 9 of those cats, or 8%, actually having a pelvis less than 2 millimeters. And just keep in mind too, these were cats that had a confirmed obstruction based on pyelography. So looking at ultrasound results, so for all cats, so overall median renal pelvic diameter was 6.6 millimeters, with a median ureteral diameter of 3.2 millimeters. So quite dilated compared to a normal of 0.2 to 0.4. And then when you look at group 1 versus group 2, group 1 had a median ureteral diameter of 2.5, and group 2 had a median ureteral diameter of 3.8. There was a statistically significant relationship between renal pelvic and ureteral diameters, but there was no difference between the two variables in group 1 when analyzed separately. So when we look at the renal diverticula, so not just the renal pelvis, but actually looking to see if they had dilation of the pelvic or renal diverticula. They had most of them, about two-thirds to three-quarters in both group where that was documented or reported. So those that had pelvic diverticular dilation had a larger renal pelvic size of 8.3 millimeters. And then those that did not have pelvic diverticular dilation had a smaller renal pelvis of 3.5 millimeters, which makes sense. And then the only statistical significance was renal pelvic size and pelvic diverticular dilation. So no significance between ureteral diameter and having diverticular dilation. Then there was no statistical significance between pelvic size and patient age or ureteral diameter and patient age. So then when we look at causes, so out of they had 114 total ureters. So again, most of those were unilateral, but some were bilateral. Ureteral lithiasis was certainly the most common at 70% of those. And more of those probably were in the group 2 or having the larger renal pelvic size. So 74% in group 2, 60% in group 1. And then less, so 30% of cats did not have confirmed ureteral lithiasis. And then most of those, 31 out of 34, were a suspected ureteral stricture or ureteritis. And then 3 of those had no identified etiology. And then when they, again, looked at the pelvic size between those cats with ureteral lifts versus without, those with ureteral lifts had a statistically significantly larger pelvic size at 7.6 compared to 5.2 millimeters. Which in the grand scheme of things, so I would probably call it like 7.6 to 5.2. Like those are still pretty big pelvises to me. No statistically significant difference between ureteral diameter and ureteral lithiasis. When you look at serum creatinine, so no surprise, 96% of the cats were azotemic at admission. And then most of those cats were still azotemic at the time of discharge, which most of these cats have a significant AKI, so expecting them to be completely resolved by the time of discharge is usually a stretch. Usually we're waiting until their 1-month recheck to really assess. And then 3 cats, though, were non-azotemic at admission. All of those actually were in group 2, having the larger renal pelvic size. And then you can see the preoperative median serum creatinine pre-op and then at the time of discharge. When we break down creatinine by group, group 1, which was the smaller renal pelvic group, actually had a higher median serum creatinine than group 2. So they had a preoperative median creatinine of 923 versus group 2 had 367. And yesterday when I put this presentation together, I did the conversion into the American units, and I've already forgotten those and forgot to write those down. So if anyone knows those quickly, if you can put them in the chat, otherwise I cannot remember what those were. And then when they looked down by type, there was really no difference in creatinine of whether they were unilateral or bilateral, other than those in group 2 that had bilateral ureteral obstruction. So they had a large renal pelvis, and bilateral ureteral obstructions did have a significantly higher creatinine. So looking at correlations with creatinine, so the only correlation found was renal pelvic size and preoperative serum creatinine. No difference in pelvic size and discharge serum creatinine, which kind of goes along with the AMC paper as well that looked at if there was any prediction between pelvic size or serum creatinine for recovery, which found the same thing. And then no difference with ureteral diameter in either pre-op creatinine or discharge creatinine. When they looked at urine culture results, 60% of them had a pre-op cystocentesis culture, and then 99% of them had an intra-op pylocentesis culture, which I think is pretty standard amongst all surgeons placing subs. And then they had an overall positive culture rate of about 21%, which is a little bit smaller than a prior paper that showed about 30 or 33% positive culture result, but almost about the same. And then when you look at the isolates, most of those were E. coli, with 70% E. coli, and then under that Staphylococcus and Enterococcus. Some other cats had preoperative antibiotics, which they talk about in the discussion may have skewed their positive culture results of the 21%. So 51% of cats had received antibiotics preoperatively, which is probably about what we see as well too. I mean, most of our azotemic cats, by the time they actually get referred, are either like A, fluid overloaded, or B, on a lot of antibiotics with the presumption that they have AKI from pyelonephritis. So I feel like we probably see similar. And because most of theirs, 71% of theirs they were started on antibiotics greater than 24 hours prior to surgery. And most of those, half of those at 48% were fluoroquinolones. Looking at comparisons with cultures, agreement between cultures of cysto versus pylocentesis, which is probably the most important from that, was about 79%. But there were 9 cats that had a positive cysto, but a negative pylocentesis. But it's probable that those 9 cats were some of the cats that were started on antibiotics. So perhaps they had the cysto done at the RDVM, started on antibiotics. And so by the time they had a pylocentesis, they were culture negative. And then 1 cat did have a positive pylocentesis culture with a negative cystocentesis culture. They did find that renal pelvic size was correlated with having a positive pylocentesis culture, but no correlation between ureteral diameter and urine culture results. So overall in the discussion, 26% of cats, so about a quarter of cats, had a renal pelvic size of less than 4 millimeters. And 8% of those cats had a renal pelvic size of less than 2 millimeters. So basically, overall conclusion from this study was that ureteral obstruction in cats cannot be excluded based on the absence of obvious renal pelvic dilation or ureteral dilation. The most common cause of ureteral obstruction was ureteral lithiasis, which has been shown in multiple other papers. And those cats did have a larger renal pelvis. Cats with a positive pylocentesis culture also had a larger renal pelvis, but those cats also all had ureteral lithiasis as well. So it's difficult to know for sure. Subs were successfully placed in all of these cats despite the renal pelvic size. And so those ones with a small renal pelvis had the nephrostomy tube extending into the ureter and not looped. Many cats in the study had pre-op antibiotics by their primary veterinarian, so that positive culture result of 21% may not be accurate and may be kind of underrepresented. And so the other thing that they discuss in this, in their discussion, talking about small renal pelvic size, is there are some papers, especially in people, that show renal parenchymal and or capsular fibrosis associated with chronic kidney disease could actually limit that renal pelvic dilation and or renal megaly in an obstructed kidney, which could owe to the decreased compliance of fibrotic tissue despite the increased pressure within the collection system. But certainly we don't have those same kind of studies in veterinary medicine. So they discuss, should we be considering something like renal biopsies during subplacement? But, most of these cats are pretty fragile. Some of them are fragile by the time they get to subplacement, and then cost would probably be another concern with biopsying all of them. But they did find those group 1 cats, those ones with a small renal pelvis, did have a statistically higher median serum creatinine. So perhaps this does play a role in vet med too. 39 to 94% of the cats with ureteral obstruction did have evidence of chronic renal changes on ultrasound, and that's through multiple studies. And then we know, based on the JAVMA study in 2017, that there is a positive association with chronic kidney disease and urolithiasis in cats. So limitations of the study, it was retrospective, and so there could be certainly some inter-radiologist variation throughout the 6 years that they looked. It was also unknown how many of these were complete versus partial ureteral obstructions, and then their maximum detection, the serum creatinine, based on their analyzer that they had utilized. So some of them may not have fully represented their serum creatinine. So I think overall conclusion and still discussion points to open the floor. Overall conclusion is that ureteral obstruction in cats can be associated with minimal renal pelvic dilation. And I think that probably the biggest thing that plays into the role is having that agreement between nephrology, urology, surgery, and the radiology team. I know that's something still we struggle with occasionally, kind of getting everyone on board to agree that this cat is obstructed and needs to go to surgery. And then still I want to open the floor too and see how many people were actually doing pre-op pyelography versus, if you obviously have a suspicion high enough, it's just going and doing intra-op pyelography. And then again, just current challenges of ureteral obstruction is that diagnostic confirmation. So ultrasound sometimes can be misleading, especially in these small renal pelvic sizes. Understanding exactly when to intervene, how often do you do medical management versus going straight to sub, and then surgery versus sub based on surgeon comfort level, number and location of ureteral lifts, and their risk of continued stone formation and recurrence. So I think that's all I have for this, but would love to hear anyone else's experience on what you do in your institution when you have a cat with a small renal pelvic size, but you're pretty sure has a ureteral obstruction. And then I also want to hear people's experience if they are using preoperative pyelography, and if you feel like that is beneficial and has helped you in some of these cases. That's all I have, so I'll open it up.
Thanks, Allie. That was great. Julie had raised her hand. Julie, do you want to share some comments? We can't hear you, Julie, if you're trying to share anything with us.
Sorry, of course, the mute thing. Our surgeons don't cut these unless they're at least 4 millimeters dilated because they don't feel like they can get the wire in. Like it's not a open enough target, I guess, is the comment that they've made. And I don't know that I don't think they tend to do the running the catheter, the nephrostomy tube down the ureter. I know that one of them had consulted with Chick on a case where we had a lot of post-op bleeding. And he had suggested doing that because she thought that the bleeding started, like she nicked a vessel when she curled the tube when she locked it, so she didn't lock the one after that, but when she had to replace it. But anyway, the point is, how difficult is it? I mean, I guess I'm not the one placing the needle. The radiologist doing the ultrasound would be, actually, in our situation. How difficult is it to do a pyelogram in a non-dilated renal pelvis? Like, how hard is it to get the needle in? And how hard is it to get, for those of you who have actually done these, and because I know Marilyn does them, and puts the nephrostomy tube in, you still got to get a needle and a wire into the renal pelvis. And if it's not dilated, how hard is that to do?
Yeah, I don't know. That's why I would love to hear other people's, because we don't routinely do them that often. I feel like if we feel like they're obstructed, we just like could try everything we can do to convince our surgeons to just go to sub and do it intra-op. But I would
Yeah,
love to, yeah, to hear if anyone does them preoperatively.
that's our experience as well. We Nav, when he was a resident of mine, we wrote the paper on pyelocentesis because at Penn we had to convince the radiologist, who would be the only ones to convince the surgeons to take a patient to surgery. So we ended up doing a lot of pyelograms there because they wouldn't believe us. And I'm very happy to be in a place that I don't have to convince the surgeons. I just tell them it's obstructed and they'll take it, which is much nicer. It can be really hard to hit the pelvis when it's really small, both doing it ultrasound guided. You're probably a little bit better prepared because you can use the needle guide on your ultrasound and watch it in real time. Doing it intraoperatively, um, sometimes you can hit the pelvis maybe a little bit further caudally and actually inject some contrast into it to confirm, yes, you're in the pelvis, and that can widen the pelvis and actually give you a bigger target. You obviously don't want to do that very much, but you can sometimes get a couple extra millimeters of pelvic width to then when you hit it to pass a wire down the ureter, you have a bigger target, but you don't have that inner anatomy to guide you because you're just looking at the serosal surface of the kidney. So it can be tough. Once you have a wire in the pelvis, once you have the needle in the pelvis, then presumably you can get a wire in, but the question is, can you get the wire down into the ureter, which really starts by if you have aligned your needle in the right path. If you're coming really caudal and you're trying to shoot it down the ureter, it's going to be really hard. So you want to really have it be quite lateral. And then also using a nice hydrophilic wire rather than a spring wire with just an angled tip rather than a J tip to be able to get a little bit of manipulation and steering and get it down there a little bit more. Our surgeons do it very well. So they only call us for those cases that are really challenging. And then we go up into the OR to help them. So we only have to help them for the ones that are annoying. But those are some of the tricks that we've done. But sometimes it can be a pain in the butt, and they've certainly stuck multiple times and they get the parenchyma to blush and they don't get the pelvis to blush, or there's leaking, and they can be challenging cases, but we still do the pyelogram intra-op rather than pre-op because I think we all have a very good sense of knowing when there's a strong suspicion for obstruction. And I think it's probably a little bit easier once you've obtained the pyelogram to then just continue the sub rather than having to move the patient up to an OR and scrub them and then basically hit the pelvis again. So we always do it intra-op.
I recall back in the days when we were placing stents in these guys, that Brian Scanson has an intra-op ultrasound that he had when he was here. He would actually like physically hold the kidney and stick the ultrasound probe on it and guide and do it like an intra-op ultrasound. Does anybody ever do that?
One of our surgeons did that for the very first couple subs that they had did. So they would bring our like good ultrasound and our radiologist into the OR, and they would do that first stick. We haven't done that in many, many, many years, but they had done it for their first couple when I think they were just still learning and getting more comfortable hitting the pelvis. And that wasn't necessarily because they were small pelvies, it was because they were not comfortable sticking a pelvis, no matter what size. So I've seen it done, but it's not something we do routinely. I don't know if other people's are doing it routinely.
And thank you very much for using the proper word for more than one pelvis.
Julie, I think that what we found, and I'm in the same position as JD, is as we don't have a fight with surgery. If we say it's obstructed, it goes to surgery. Pretty much all of our subs are placed by one surgeon who is phenomenal. He's probably the best person I've ever seen place subs, and I have zero doubts that we will get a tube in regardless of the pelvis size if we need to. And we use some of the techniques that Marilyn's described. We place a lot of ureterostomy tubes. Sometimes we'll have cats where the ureter tapers very, very proximally. And so we will also sometimes shorten the nephrostomy tube as well. But I think what we have found is that by having the one team place all of the subs, even if that means waiting a day or two, we get much better success. And our patients, for the most part, do really, really well. We also use, as JD mentioned, we use a shortened, you can order from Infinity a 50 centimeter 035 hydrophilic guide wire, which makes it really easy and certainly much less traumatic to the pelvis than using the spring wire that comes with the kit. So yeah, we will theoretically offer a pre-op pylocentesis, but so far, our owners have been comfortable going to surgery, or their surgery is completely off the table, and therefore the value of doing a kind of percutaneous pylocentesis isn't really there if an owner's not then going to follow the results.
I can chime in a couple of things, because here at Tufts, I am mainly placing them. The surgeons help to be, they're much faster for the approach, but the placement in the kidney, I tend to do them. And I completely agree. What makes a huge difference is using this hydrophilic guide wire. And when the pelvis is extremely small, what helps is to have an approach not necessarily from the caudal pole, but a little bit more directly against the ureter, like facing the ureter, so that we are, as soon as we hit even like the 1 millimeter dilation, we are straight, like in the right direction to get in the ureter. And so I agree with JD. If once we are in the pelvis, as soon as we inject a little bit of contrast, we have this extra 2-3 millimeters of dilation that helps us guide this hydrophilic guide wire, which is quite safe. So even if we have to wiggle in one direction or the other until it goes down the ureter, that really makes a smooth way down the ureter. And I tend to use just the vessels of the kidney to help me guide also, to see where is my guide, where is going to be my pelvis, if we don't have a great image with the C-arm right away, if the pelvis is really small. So I just go extremely slowly following my blood vessels. And as soon as I hit the pelvis, I can play with my contrast and the guide wire. And to go back to the question of the ultrasound guidance, I wrote an article on that because that's what was happening at Tufts when I was a resident. And I've basically been trained by Marilyn in Montreal, and then arrived at Tufts, and they were doing the ultrasound guidance. And I sort of wrote this article to describe the method, but to be honest, it's extremely, extremely hard, much harder than with the fluoro guidance. So I actually don't necessarily recommend that, because it is much harder than it looks like, except if the pelvis is really big. And then I'm not sure that there is a huge improvement to use the ultrasound versus just going blindly, to be honest.
Thanks. I think that was, I think it's helpful seeing what other people do at other institutions. I think the nice thing with all these papers coming out, and probably with the nephrology urology specialties, I certainly have noticed in the last probably year or two, our surgeons trusting us a lot more to make these decisions. And I feel like it's since we've had the specialty probably that they are much more apt to believe us when we say they're obstructed and to take them. But we're kind of the same. We have one younger surgeon who actually did her residency with me, and so she was trained to place subs by Larry Adams, and she will place them despite what the pelvic size is. But we have the older surgeons who aren't as used to placing them in small pelvises take a little bit more discussion with, although I've had the last 2 cats I've sent for subsurgery have had a pelvis less than 5 millimeters. Both of those went to the older surgeon, and he placed a sub beautifully in both of them. So he owes me like dinner out or something now, because I'm like, I told you could do it, because they both went great. He just needed like a bit of confidence boost.
I think
Hey,
the other
Allison. Oh,
sorry.
Hey.
I was
Hey,
just going to say, I think feedback to radiology is really important as well. I think our radiology team, I think partly because they, we have the cases with really small pelvises, they much more, rather than trying to say whether it's obstructed or not, they just focus on the description, which I think is much more helpful information. So I think it's really important to be giving the radiologists feedback, because then I think they're much less likely to say definitive things that might discourage surgeons from cutting things.
Yeah, I think that's a great point. We actually had this discussion in our journal club with our medicine residents recently, and brought up that exact point, is that a lot of times our radiologists will just say obstructed or non-obstructed on the ultrasound report. But if you go down there and talk to them, they actually want to know why we think the cat is obstructed. Because, they don't have all the lab work in front of them or the physical exam in front of them. And I feel like once we give them all of our reasonings for why we think it's obstructed, they also do the same. They leave the report very open and subjective, which has helped us a lot with then getting these cats to surgery too.
I also wanted to piggyback off of what Karina was saying, because we get a lot of mobile ultrasounds that are performed. And I think we had one even this last week where bilateral ureteral obstruction was quite obvious on the ultrasound. It wasn't even a differential for the radiology report. And so it just is like very much an education thing as well, where, even as radiologists that are out in the field, they're being asked to make diagnoses off of their diagnostic imaging. And it's a really tough battle that we're always facing with having to repeat ultrasounds because of what has been described or what isn't described. And so that's always the biggest challenge that we face.
I 100% agree. In our institution, it was the same. We had to do multiple journal clubs, sort of discuss the new finding, describe the fact that they are one pieces of the puzzle, but we sort of have the luxury of having kind of all the pieces of the puzzle to end up with a diagnosis. And so we really had multiple meetings to make sure that they at least keep an open diagnosis, and that we sort of get away from, it is increase in size, it's pyelonephritis, and we don't even talk about a potential obstruction. But I think that there is this article that was describing the different pelvis sizes, and it sort of stuck for a very long time, the fact that it had to be a pelvis, I think it was more than 10 millimeters, or to really ensure that it was obstructed. And so I think that in the radiology world, that stuck for a very long time, and we had to sort of circle back and tell them that no, unfortunately, this is much more complicated than just a number.
Well, this has been great. Thank you everyone for participating and giving experiences. I don't know if anyone has any last words of wisdom or advice for diagnosing these cats and getting them to surgery, or other things that have worked well in your institution. Okay, great. Well, that's all I have, unless Summer, you have anything else for everyone?
No, that was great. Thank you guys very much. We'll see everybody next week.
Thank you.